Welcome to today's webinar for FQHC and RHC leaders, the hidden financial value of chronic care management programs and the different ways you can derive revenue from a well-run CCM program. Excited to have Jennifer Towers, ChartSpan's Director of Quality, and Shannon O'Neill, ChartSpan's Director of Client Experience, join us today. Shannon's job is to make sure the clients onboard successfully, and Jennifer's job is to make sure we close care gaps and leverage CCM programs and achieve great quality scores. My name is John Michael Carter. I'm the CEO of ChartSpan. Real quick, just about ChartSpan. ChartSpan is the largest provider of chronic care management programs in the country based on patient enrollment. About 1 out of every 10 Medicare patients enrolled in a CCM program is enrolled in a ChartSpan program. We're proud of the fact that last year in 2020, we saved taxpayers and Medicare more than $40 million through our programs and generated nearly $25 million in fee-for-service reimbursements and shared savings. When we think about chronic care management and its preventative care potential, we really need to start with the patient care journey and how it largely today is reactive. When you think about value-based care and you think about the care journey in front of you, where does prevention occur in this process? The truth is it doesn't. And the truth is we're not very good at value-based care. If you look at the claims data, every single year since we launched value-based care initiatives, the average cost of a Medicare beneficiary has increased. The truth is we need to get better at value-based care and preventative care. One way to do that is to rethink the sick care journey. Don't separate preventative care from the normal patient experience. Instead, insert it into the sick care journey. The moment a patient is diagnosed with a chronic condition, get them enrolled in a chronic care management program before they become high acuity. And the data shows remarkable success when you can do that. You drop the average cost of a Medicare beneficiary per year by nearly $1,000 when you can get them enrolled in a CCM program. Now, this is CMS claims data. This is looking at all the cost savings achieved over a 2-year period for every single patient enrolled in a CCM program in the US. And what's so great about these programs is they represent a dual stream of revenue, not just the fee-for-service revenue you'll generate immediately through reimbursements, but the cost savings that you can achieve in things like ACO programs or MSSP programs. Shannon, I really want to orientate everybody to what the core tenets of a CCM program involve.
Yeah, there are really 4 ways an effective CCM program can have an effect on preventative care. The first is reinforcing a provider's treatment plan. CCM outreach, maybe on a monthly call to a recently discharged CHF patient, a clinician might cover things like ensuring that the patient is maintaining a low sodium diet, maybe making sure that they're using the medications or taking the medications that they were prescribed as prescribed, maybe checking and also reporting their weight.
I love that you use the word reinforcement there, because for some providers, they think, okay, if I engage, a third party like ChartSpan to help me drive these programs, they're going to be introducing new care plans. That's not the case at all.
Correct.
Our job is really to enforce them.
And social determinants are non-physiologic factors that affect a patient's outcome. Things like transportation, meals on wheels, maybe connection to local resources. CCM programs can help to alleviate some of those obstacles that may get in the way of the patient's health. Assessments and medication review. CCM provides a perfect opportunity every time we're reaching out to those patients monthly, just to go over some basic, simple questionnaires to maybe check and make sure that the patient is not at risk for falls, that they are following medication adherence per their provider's treatment plan, just making sure that they're getting around the house okay. Those types of things affect the treatment plan the provider has provided for the patient. Certainly gaps in care. CCM provides another opportunity to get those patients into the practice for preventative services, hemoglobin A1Cs or patient education, maybe some BMI screening or conversation. CCM provides a great opportunity for that as well.
I want to also address the different silos specifically, that as we talk about the hidden value of CCM programs. Preventative care is a big one. Shannon, I want to come back and talk about that in a second. One of the obvious ones is fee for service and the way you generate reimbursements for the program. Maybe not so obvious is the way those programs then impact you as you think about shared savings programs or ACO participation. Jennifer, I want to talk with you in a little bit about how quality scores can impact revenue and how you can leverage a CCM program to really drive those scores. And then for those folks that are either in a patient-centered medical home program or thinking about one, care coordination is critical. So let's start with prevention. Shannon, we saw some interesting data I referred to earlier around that 2-year retrospective claims analysis that CMS did. The data that was interesting to us was that for every patient enrolled in a CCM program, there was an 8% increase in annual E&M encounters.
Right. Effective CCM programs, we're reaching out to those patients every month. We're going to identify areas where the patient maybe needs to get in to see the provider. So for example, if we do a fall risk screen, then a fall risk assessment needs to be done on site with the provider. Perhaps it's more attention to their medications. Maybe they're not taking their medications correctly. Maybe they just need to come in for a non-urgent visit with their provider instead of going to the emergency room.
Of course, as you think about the clinical data set that gets created, it's called a patient health summary, at least it is between ChartSpan and its clients. It's been really interesting to watch what many of our clients do with that patient health summary that gets generated by the CCM clinician as you think about applying it to preventative care.
Oh yeah, I love the innovation of our clients as we hand them these tools. Using the patient health summary is one of them. We have the diagnoses, we have care goals, we have obstacles that the patient has explained to us. And then we also have their progress for each specific patient month over month. And providers should use this information to identify or target areas where they may be able to work with a patient on prevention. Things like patient education, that would be the most common.
So that's prevention. Let's then move to that second silo that we talked about around fee for service. I want to give some very real world numbers so that an FQHC or RHC leader can really begin to understand what's possible from a revenue perspective. And clearly, this is the largest revenue bucket that can be derived fee for service. So what we did is we took 2,000 patients. What we didn't do was forecast or project numbers that aren't real. Instead, we're using our historical averages at ChartSpan across our more than 100 customers to really give you a real world sense of what's possible. So 2,000 patients, we know that 82% of them are going to be eligible. That means 2 or more chronic conditions. And we know at ChartSpan, our average enrollment rate where a patient consents and agrees to be in the program is 55% of those patients, so roughly 902 patients. Now, big news, if you're listening to this in late 2021, there's going to be a substantial increase in the reimbursable rate effective January 1st of 2022 for RHCs and FQHCs. It was already a significant reimbursement. That's going to go now from about $66 to almost $79. It's $78.87. Transparently, our rate is $39.18, so it's about a 50-50 split. That means the practice earns about 50% net margins. Now, I don't know about you, but there's not many things we do in healthcare where a practice can generate 50% net margins. One thing that's important to do as you think about the revenue is be honest and practical in thinking about copay defaults. So we know the national average for copay collection is roughly 82%, or inversely an 18% default rate. So when you factor all those things together, you're going to generate nearly $370,000 a year based on 2,000 patients in net revenue. That should get the attention of every FQHC and RHC in the country. So let's move to the next silo around ACOs, around shared savings programs. So we know a lot of RHCs and FQHCs rather don't participate in ACOs, but it's been interesting over the last year or two, we've seen significant increase in the number that are participating. And when you look at the claims data, again, that 2-year claims analysis that CMS did, and you take out the reimbursement. So it's not gross, it's net. What are we saving taxpayers in Medicare? It comes to a total of $30 per patient per month. Contrast that with a typical ACO, and you look at their numbers last year. Across all ACOs, they saved only $15 per patient per month. Now, I love ACOs. They have a part in healthcare and what we do. But boy, if you want to really contribute to shared savings, you must have a CCM program in your ACO program that really focuses on closing care gaps and driving quality measures. And then if you begin to monetize that and think about, well, what's the value of that? What does that generate for income? Again, same 2,000 patients, only Part B now, right? So that's your 60% that are roughly Medicare, or 984 patients. We know that 82% of them are eligible. And then we know historically we enroll about 55%. So that reduces that number down to about 541. In the upper right-hand corner is kind of a complicated math formula. That's because you need to factor a different savings if the patient's been in the program for less than a year versus more than a year. There's a huge increase, by the way, if a patient stays in the program for at least a year and the cost savings that can be achieved. So the net there is about $20.91 per patient per month that you use to calculate shared savings. We conservatively forecast that only half of your eligible patients are attributed beneficiaries within your ACO. So when we look at that, it's about 68,000 in what you save Medicare. We assume you're in a track one, no downside risk, 50% shared savings. So you cut that number in half, but it's still about $34,000. So that represents about 10% of the total fee for service. That's not insignificant. And that's a big number, especially when you think about the recurring nature of that year over year. So Jennifer, let's move to the silo of revenue that I'm fascinated with, which is how CCM impacts both traditional Medicare compliance programs as well as Medicare Advantage programs.
Yeah, so let's dive further into the process we have here at ChartSpan, where we can actually help you achieve higher quality scores, which is going to lead to higher reimbursement. So the process we have in place here is we will obtain care lists from our patients, care lists from our clients, open gaps and care lists, and then we're going to take those and we're going to ingest those into our system. What it's going to do is it's going to behind the scenes is going to mirror that with our patients who are currently enrolled in CCM. So when our patient care coordinators are having conversations with them, they'll be able to see what open gaps in care they have and address those with them on the phone. The good news is we will help you do some chart chasing if that patient tells us they already had a mammogram done, for example. So we'll save you some time and effort by going and getting those records for you. And then we also will drive them back into your practice if we need your help in closing that care gap. That is going to lead to higher quality scores for you, which in turn is going to lead to higher reimbursement.
This is so important because I think too often we give lip service to, a CCM program can help you close care gaps. And then nobody ever holds anybody accountable for whether that actually happens. Very different from our perspective. That's really your job, Jennifer, is to make sure you're leveraging each client's CCM program. So you work with a quality team from a particular client, identify what their focus is that month, that quarter, and then you're driving those instructions to the CCM clinicians to make sure that's their focus, right?
Yes, we want to, we're going to have conversations with our clients, figuring out what are their quality initiatives, what are their top 3 focuses for those quality measures, and make sure we're working hand in hand with them to achieve those higher quality scores.
Well, I'm proud of the work your team does. There's one piece of data that always stands out to me. A majority of our customers last year scored a perfect 100 MIPS score. I don't think there's any telltale sign about how more a CCM program can impact quality than actually looking at those scores. So great job by you and your team. So let's continue here as we think about patient-centered medical home, the last bucket of revenue opportunity that we wanted to identify for FQHCs and RHCs. How does a CCM program impact a PCMH?
So, our CCM program can help you meet the requirements that are required for the care management and support portion of the NCQA standards and guidelines. A lot of clinics struggle with this. They just are not staffed appropriately to handle the volume of patients you're looking at. It's just hard. This is a hard measure to meet, but our CCM program meets all these requirements already for you. We're able to identify which patients are eligible for CCM. We're also able to use our protocols in place to know who we need to outreach. Who are we going to try and get enrolled in our CCM program? And then, as Shannon alluded to earlier, we have our patient care plans already built that are very specific and detailed and meet all of NCQA's requirements. So once you have your PCMH certification, you can leverage with your MCOs and your payer programs and get additional PMPM for CCM revenue, or you can also get some additional money for your PCMH certification.
Well said. It's a head scratcher to me when I encounter customers who are participating in a PCMH but not getting paid for care coordination. Yes, it's a requirement. You have to, but there's a way to get paid for it. And that's, running these prevention CCM programs through Medicare and Medicare Advantage. So in summation here, as we think about the different revenue opportunities with the CCM program, clearly, the majority of the revenue comes from fee for service, but there is not an insignificant amount of revenue that comes through shared savings programs, the lift in E&M encounters you're going to see through the preventative work of the CCM clinicians, the way that you can impact Medicare Advantage and CMS quality programs. We don't have the specificity of revenue there because it's unique to each client, but certainly that's tens, sometimes hundreds of thousands of dollars a year. So just in this case right here for 2,000 patients, you're talking about a minimum of $400,000, potentially $500,000 a year in recurring revenue. And 2,000 patients is not a large health system. So it really needs the attention of every FQHC and RHC leader as they think about the impact that CCM can have. Shannon, Jennifer, thank you for your participation today and your wisdom. We're grateful. And if you'd like to learn more information about ChartSpan, feel free to go to our website, chartspan.com.